will give you an overview on the most common cause of sudden cardiac arrest, acute coronary syndrome. At the end of this module, you are expected to recognize patients suffering from acute coronary syndrome and know the initial management of patients presenting with it. I will give you a brief overview on ACS, followed by the clinical presentation, ECG changes, and appropriate initial management. I will also introduce to you the locally developed application that will help you manage your heart attack patient. What is acute coronary syndrome? ACS is a syndrome that results from sudden significant decrease in blood flow to the coronary arteries. This leads to death of the affected muscles of the myocardium, which leads to decline in function. Acute coronary syndrome is regarded as the most common proximate cause of sudden cardiac arrest. ACS presents with chest pain accompanied by ECG changes and the elevation of cardiac biomarkers such as troponin and CKMB. The most common cause of ACS is plaque rupture, leading to occlusion of a coronary artery. When an artery is acutely and totally occluded, ST elevation acute coronary syndrome occurs. Acute partial occlusions result in non-ST elevation acute coronary syndrome. Cardiac function largely defines an individual's functional status. Damage to the myocardium can result in undesirable events. Thus, the goal of ACS management is to reduce myocardial necrosis, treat acute life-threatening complications, and prevent major adverse cardiac events. To help us recognize acute coronary syndrome, let us review its clinical manifestations. ACS typically presents with chest pain. Angina pectoris is the term used when the discomfort originates from the heart. The pain can be described using the OPQRST. O for onset, P for provoking and palliating factors, Q for quality, R for radiation, S for site, and T timing. The chest pain of ACS is usually sudden in onset with increasing intensity. It is usually provoked by physical activity or extreme emotional outbursts. The pain may or may not respond to sublingual nitroglycerin. Patients who suffered from a heart attack describe it as squeezing, tight, heavy, or crushing. Patients often find the pain diffuse, with no identifiable single location, and the pain usually radiates to the upper abdomen, shoulders, neck, arms, and jaw. In contrast to chronic angina, the pain in ACS usually lasts more than 30 minutes. In summary, the chest pain is sudden onset, precipitated by inactivity, described as squeezing or heavy, diffuse with radiation to the shoulders, arms, neck, or jaw, lasting more than 30 minutes. In addition, patients who suffer from ACS have the following risk factors: uncontrolled blood sugar, smoking and poor diet, family history, poor fitness and obesity, insulin resistance, kidney problems, dyslipidemia, and hypertension. Once you have identified patients who might be having a heart attack, ECG interpretation is crucial in the management of ACS. Let us have a quick review. These are your ECG waveforms: the P wave, the QRS complex, and the T wave. Of particular importance is the ST segment as highlighted in the strip. The ST segment is normally isoelectric that may normally deviate between 0.5 to 1 mm from baseline. In the spectrum, the ECG determines the type of ACS we encounter. Those patients who present with ST elevation will be labeled as having ST elevation acute coronary syndrome, while those with ST depression or T wave inversion will be labeled as non-ST elevation acute coronary syndrome. The importance of distinction of the two will be discussed later in the management. The leads that show ST changes correspond to specific areas in the heart. V1 and V2 correspond to the septum. V3 and V4 represent the anterior wall, while V5 and V6 correspond to the lateral wall. Leads 2, 3, and AVF reflect the inferior wall, while 1 and AVL the high lateral wall. Now let us look at some examples. Kindly focus your attention on the leads highlighted by the red boxes. Note the ST segment elevation in leads V1 to V3 and 1 in AVL. Hence, this ECG is read as anteroseptal and high lateral wall myocardial infarction. On the other hand, this ECG shows ST segment depression in multiple leads as pointed by the arrows. Patients with clinical manifestations of ACS together with this ECG would help clinch a diagnosis of non-ST elevation acute coronary syndrome. This third example exhibits T-wave inversions. Similar to the previous slide, when this ECG accompanies clinical manifestations suggestive of ACS, the patient may be labeled as having non-ST elevation acute coronary syndrome. To highlight the recommendations by the International Liaison Committee on Resuscitation, it is recommended that patients undergo pre-hospital ECG. This is to allow the receiving hospital to prepare the appropriate management in the receiving hospital. Computer-assisted interpretation of ECGs may be used to help EMTs transporting patients relay the result to receiving healthcare institutions. Once an acute coronary event is identified, initial management becomes very crucial. Let us take a look into this case of a 54-year-old male who is hypertensive, diabetic, and a smoker. He presented at the ER with sudden onset chest heaviness of 30-minute duration that was not relieved by nitrates taken sublingually. Given this situation, what is the best thing to do in this case? The general approach to ACS care starts with initial assessment, followed by ECG interpretation that will dictate a more definitive management. The initial step is to do primary survey. If a patient has a high clinical probability for ACS, aspirin should be given. Note that you have to ask the patient to chew the tablets before swallowing. If patient still complains of chest pain, you may give nitrate sublingually every 5 minutes. IV morphine should be considered if patient remains in severe chest pain. IV access should be established. Blood tests should be done. O2 supplementation is only given if saturation level is less than 90%. It is important to hook the patient to a cardiac monitor, and lastly, ECG should be taken. It must be emphasized that all of this as part of the initial assessment and care should be carried out in less than 10 minutes because time is of the essence in ACS management. Time is muscle. Going back to the case, patient still complains of chest pain with dyspnea with a blood pressure of 110/70 millimeters mercury, a heart rate of 112 beats per minute, a respiratory rate of 26 cycles per minute, and an O2 saturation of 88%. What will be your initial management based on what you have learned so far? A. Give aspirin. B. Start oxygen support. C. Insert IV access. D. Get 12-lead ECG. E. Give sublingual nitrates. F. All of the above. If you answered all of the above, then you are correct. Good job! Remember that everything should be done in 10 minutes, and if the ECG obtained is non-diagnostic, you have to repeat the ECG at 10-minute intervals to observe changes in the ST segment. Going back to the case, let me show you the ECG. What do you see? In leads V3 to V6, the ST segment is elevated. With this, we can say that a patient has anterolateral wall ST elevation acute coronary syndrome. Now that we have a more definitive diagnosis based on the ECG, how do we proceed from here? Here is the general algorithm in the management of ACS. Note that key to the direction of management is a 12-lead ECG. Going back to the case, the patient presented with ST elevation acute coronary syndrome. So we follow the path of the ST elevation ACS. Adjunctive therapy should be started and reperfusion should not be delayed. The time of onset of symptoms is important in the management. If the onset of symptoms is less than 12 hours, reperfusion is warranted via thrombolysis or angioplasty with a goal of door to needle time of 30 minutes or door to balloon time of 90 minutes. In terms of benefit, studies have shown that if a patient with ST elevation acute coronary syndrome presents at the ER within 2 hours of symptom onset, fibrinolysis is more effective than percutaneous coronary intervention or PCI. If a patient arrives at the ER within 2 to 3 hours of symptom onset, the benefit is similar for both fibrinolysis and PCI. However, if a patient presents more than 3 hours from symptom onset, PCI is favored over fibrinolysis. Note that after 6 hours, fibrinolysis becomes less effective because thrombi in the coronary arteries have become more organized and becomes more difficult to lyse as time goes by. What do you do if the patients with ST elevation ACS present at the ER more than 12 hours from the onset of chest pain? We consider invasive strategy if the patient has refractory chest pain, persistent or dynamic ECG changes, ventricular tachycardia, hemodynamic instability, or signs of heart failure. Adjunctive therapy should also be started, and if there is difficulty in risk stratification, the patient should be referred to cardiology service for further expert management. Going back to the case, since the onset of symptoms is 4 hours and the patient is in a PCI-capable hospital, patient was referred to interventional cardiology and angioplasty was done. Now let me show you a different ECG. What do you see? I hope you appreciate those ST segment depressions in multiple leads, actually in almost all leads. You are right. The patient has diffuse ST segment depression. With this ECG, this patient may be having non-ST elevation acute coronary syndrome. So how do we manage this patient? If the patient is classified as high risk, an invasive strategy should be considered. Otherwise, conservative strategy with medical therapy should be initiated. For patients who do not fall into the high-risk category, referral to cardiology for risk stratification and further management should be done. Going back to the case, the patient has ongoing chest pain with difficulty of breathing. He has a blood pressure of 90/60 millimeters mercury with heart rate of 88 beats per minute, a respiratory rate of 26 cycles per minute, and an O2 saturation of 88%. On cardiac monitor, he has episodes of non-sustained V-tach. Based on the case, our patient is considered high risk and invasive strategy should be considered. Patient was eventually referred to interventional cardiology and he underwent coronary angiogram revealing significant severe three-vessel coronary artery disease with left main involvement. Patient was referred to surgery for bypass. Let me show you another ECG. What if the patient in our case had this ECG? What do you see? Are there any obvious ST segment elevation? Or any ST depression? Or T-wave inversion at least? There are none. The only remarkable finding in this ECG is that his heart is running fast. This ECG shows sinus tachycardia and nothing else significant. Going back to the case, patient now denies chest pain. He is flat on bed and comfortable with an elevated blood pressure of 150/90 millimeters mercury and tachycardic at 115 beats per minute. Based on the treatment algorithm, we admit the patient for observation for development of any high-risk criterion. Troponin or cardiac markers and ECG are serially monitored. Patient was subsequently admitted to the chest pain unit. He remained stable and did not develop significant ECG changes. Serial troponin monitoring was also negative. Patient was eventually sent home and advised on close follow-up. Here is an additional case. A 57-year-old male who is hypertensive and diabetic suddenly developed chest pain and went into sudden cardiac arrest. He was fortunately revived and at the ER He is awake but dizzy and still complains of the same chest discomfort. What should be done in this case? According to the 2015 ILCOR recommendations, coronary angiogram should be performed emergently in patients who went into out-of-hospital cardiac arrest with a suspected cardiac cause and ST elevation on ECG. Our patient was referred to cardiology service and underwent an invasive procedure. Earlier adjunctive therapy has been mentioned in the management of ST elevation acute coronary syndrome and a high-risk non-ST elevation acute coronary syndrome. Adjunctive therapy include additional antiplatelet with ticagrelor, prasugrel, or clopidogrel, renin-angiotensin aldosterone inhibitors, heparin, statins, and beta blockers. Remember that you should always check for contraindications against any medications mentioned prior to initiation. Now let me introduce to you to the STEMI Consult app. To guide patients and physicians in particular in the management of ACS, the Philippine Society of Cardiac Catheterization and Intervention, a component society of the Philippine Heart Association, launched the STEMI Consult app in 2019. This application is available to both iOS and Android mobile devices. This enables users to locate centers where they can go to in case of a heart attack. This also enables non-cardiology doctors to be guided on managing patients with acute coronary syndromes, as this app offers algorithmic management for acute coronary syndromes. Doctors can also get connected to PCI-capable hospitals where they can send their patients to for further intervention. To download the app, you may scan the QR code flashed on your screen using your camera for iOS users, or you may use a QR code scanner for Android users. In summary, ACS is the most common proximate cause of sudden cardiac arrest or cardiopulmonary arrest. Important in management is to limit cardiac injury and prevent major adverse cardiovascular events. The general steps in ACS management include initial assessment and care, followed by ECG interpretation that dictates definitive management. In the first step, focused history and assessment should be done to establish the high probability of ACS. Initial management include giving aspirin, oxygen for saturation less than 90%, nitrates, or morphine. The second step is ECG interpretation because this will guide the direction of management. Recognition of ST elevation acute coronary syndrome and high-risk non-ST elevation acute coronary syndrome is important because this will warrant urgent specialty referral for reperfusion therapy and a more definitive management. With prompt and appropriate interventions, we can save more patients from the undesirable consequences of heart attacks. Remember that time is muscle. Thank you for listening. You have now completed the online lectures for the Advanced Cardiac Life Support Training course of the Philippine Heart Association. You are now ready to take workshops on airway management and ventilation and electrical therapies.